Hi everyone. Welcome to this pre-recording. This is going to be over the first portion of the back lecture content on the vertebral column. So we will talk about the regions of the vertebral column or spinal column, the four curvatures, structures of a typical vertebrae, as well as regional characteristics of each vertebrae, the joints of the spinal column, and then the ligaments that support those joints. So first, the vertebral column. The vertebral or spinal column is made up of 33 vertebrae. Just as a side note, when you see AE in any of the terms that we talk about this semester, that is a way to pluralize that word. So it's vertebrae with just an A when we're talking about one, and then AE when we were talking about more than one. So there are 33 vertebrae that make up the spinal column. And then between those vertebrae are intervertebral discs, all except between C1 and C2. And then the ligaments that support the spinal column. The vertebral column is separated into 5 regions. The most superior region is the cervical region. Cervical is talking about the neck. So cervical region makes up your neck portion of your spine. Then thoracic portion is in the middle, associated with your bony thorax. Then the lower portion is the lumbar region. And then the very bottom is your sacrum and your coccyx. Again, 33 vertebrae, 7 of those come from the cervical region, 12 are in the thoracic region, and 5 are in the lumbar region. And then the sacrum and coccyx are segments that are ultimately fused. The sacrum is made up of 5 fused segments, and the coccygeal segment or coccyx is 4 fused segments. Typically, people remember you have breakfast at 7, lunch at 12, and dinner at 5, to remember the number of vertebrae in each of those cervical, thoracic, and lumbar regions. Again, the vertebrae are separated by intervertebral discs. Those discs help provide cushion, create some height in the spinal column, and give the spinal column some spring-like flexibility. And then the ligaments are reinforcing. The ligaments, remember, connect bone to bone. And so they are reinforcing the joints and stabilizing the bony spinal column. So the spine is not, in a healthy individual, is not a stick straight rod. There are curvatures of a healthy back, and that allows the spine to act like a spring and gives our spine stability while also allowing it to be flexible and absorb the shock that goes through our thorax and our trunk as we walk or move things and just go about our daily activities. It also helps give some balance to anterior and posterior structures on our body and allows for upright positioning. These curvatures are found in 4 places. So we have a cervical curvature, a thoracic curvature, a lumbar curve, and then a sacral curve or sacral coccyx curve. Those curves are categorized into 2 types, our primary curves and our secondary curves. Primary curves are called primary because they are present at birth and they're a result of fetal development. So when we are a fetus and a young newborn, we're in that fetal position, the flexed position, and we have a spinal column that is largely flexed in that fetal position, creating this curve that is convex on the posterior side, convex meaning pointing out. So on the posterior side, it points out or bulges out, and it's concave anteriorly. So on the anterior portion of this curve, it caves inward. Those primary curves present at birth remain that way in both our thoracic region and our sacral region as we develop into adults. So we have primary curves that are present at birth as a result of fetal positioning and fetal development and are then retained through life. And those are in our thoracic and sacral regions. They are curves that are convex, bending out on the posterior side, and are concave, caving in on their anterior side. Then, as a result of upright development, so we go from being a baby, can't control our head, we lay around a lot, lay flat, to children and then adults that are holding our trunk upright, holding our head upright. As a result of that development of upright positioning, we get what we call secondary curves. Secondary curves because they are developed secondarily as a result of that upright posture. And so those create what's called lordotic curves. And lordotic curves are concave posteriorly, they cave in posteriorly and point out anteriorly, a convex anteriorly. And we see that in our cervical region as a result of holding our head upright for forward gaze. And we see that in our lumbar region as a result of holding our trunk upright to keep our bodies upright. Okay, so you can see that here. 2 with a degree sign is saying secondary, 1 with a degree sign is saying primary. So thoracic and sacral curves are our primary curves, present at birth, retained through life. Cervical and lumbar curves are secondary curves, developed secondarily as a result of development of upright positioning. We have lordotic curves are our secondary curves in the cervical and lumbar spine. And kyphotic curves are our primary curves, thoracic and sacral spine. Remember, those curves allow our spine to act as a spring, give some flexibility and shock absorption to our spinal column. This slide is just showing some surface anatomy, so you'll be working through this surface anatomy as well, taking note of the normal curvatures of your classmates' spinal columns in the different regions. So again, just some surface anatomy. It's very important for us as physical therapists to be able to see only what's on the surface and have a very strong appreciation for what is deep to that surface anatomy. So a clinical pearl here related to excessive spinal curvatures. So I said that in a healthy spine, we have these curvatures, we have these healthy kyphotic and lordotic curvatures. However, in clinical practice, you will often hear kyphosis and lordosis used only in more pathological or excessive spinal curvatures. And that's these. These ones are most common ones listed here on the slide. So excessive kyphosis, often just called thoracic kyphosis, is where we see this. You can see that in this image here. Also called a humpback or hunchback, excessive thoracic kyphosis. If this is in a elderly, typically elderly woman, this excessive thoracic kyphosis is a result of osteoporosis. You sometimes will hear that called a dowager's hump. They're all talking about the same thing. It's an excessive thoracic kyphosis because remember, healthy spine has a small degree of thoracic kyphosis, but this is very clearly excessive kyphosis. We also can have excessive lordosis. So you can see that in this image here. So excessive lordosis, this can sometimes be called swayback, but often just referred to as excessive lordosis. This creates an anterior pelvic tilt where the front of your pelvis is tilted down and that person's booty often looks like it's sticking right out. So that's excessive lordosis. Again, remember, we do need some lordosis in the lumbar spine, but if we get to have too much lordosis, it becomes excessive and puts too much strain on the lumbar spine. And there's also one additional curvature. So in a healthy spine, the spine is in the midline. And these curves, the kyphotic and lordotic curves I was talking about, happen in the sagittal plane, but everything is in line. In a scoliosis, you can see here, is an abnormal lateral curve of the spine. And you can see that in this image here. So we're getting curvatures that are happening mediolateral. They're happening in the frontal plane. And that is deemed a scoliosis. Scoliosis can be structural or functional. Structural when it is bony changes that make it happen. Functional when it is due to some musculoskeletal differences, like maybe a leg length discrepancy, for example, among other things that can cause functional scoliosis. So these are three common examples of excessive spinal curvatures that are beyond what we see in a healthy spine. Okay, so moving on to a vertebrae, typical vertebrae. These are elements that are in most typical vertebrae. In a typical vertebrae, we have anterior and posterior elements. The anterior element is blue in this image and is the vertebral body. The posterior element, if you hear somebody refer to posterior element, we're talking about everything that composes and comes off of the vertebral arch. Okay, so the vertebral body is this anterior component, blue in this image, is typically large. It increases in size as you descend in the spinal column because it is the weight-bearing component of your spinal column. C1 does not have a vertebral body, but all others do, and that's that the size of that vertebral body increases as you descend, with L5 being the largest because it is bearing the most weight as you go further down the spinal column. The vertebral body, like other bones, as discussed in the introductory material, has spongy bone that is enclosed by compact bone. And again, most of these vertebral body, their weight-bearing portion, are separated by intervertebral discs that are adding cushion. As weight comes down through those vertebral bodies, we get some added shock absorption. In the posterior element, as I said, it's all the components and structures that come off of this vertebral arch. The vertebral arch, so let's go down to this colored image here. So the vertebral arch includes the right and left pedicles. The pedicles are what project directly posterior off the posterior aspect of the vertebral body. It also includes right and left lamina or laminae, if we're talking about more than one. The laminae are coming from the pedicle, and they come together at the posterior part of this vertebral arch to create one of the three projections off of this vertebral arch. Laminae come together, right and left laminae come together to form the posterior projection called the spinous process. This is what you can palpate straight off down the center of someone's back. You'll palpate these on Monday. Off the sides of the vertebral arch, you have a right and left transverse process. These are projecting towards the transverse plane. So they're called transverse processes. There are two of those, right and left. And then there are four other projections that you can see best in these side views. They're yellow in this image just for your visualization, but they can sometimes be better seen in these lateral views. Off of the vertebral arch, there are two superior articular processes, right and left, and two inferior articular processes, right and left. So in this view, you're only seeing one of each. But you see right here is a superior articular process, and down here is an inferior articular process. The superior articular process of this vertebrae is articulating with the inferior articular process of this vertebrae. Okay, and this is on one side. you have that same articulation happening on the other side, and that would happen in adjacent vertebrae up and down the vertebral column. Okay, so superior and inferior articular processes, a set of those on the right and a set of those on the left off of the vertebral arch. So all of those components, right and left pedicle, right and left laminae, that's what makes up the arch structure. Off of that arch, you have a right and left transverse process and a posterior spinous process, and then you have 4 articular processes. There are 2 foramina or foramen for passage of important structures. First, in a single vertebrae created by this vertebral arch off the posterior portion of the vertebral body is the vertebral foramen. The vertebral foramen is present, like I just mentioned, in a individual vertebrae. If you were to see multiple vertebrae stacked on one another, we sometimes call that then the spinal canal. But in an individual vertebrae, we're calling this the vertebral foramen. Vertebral foramen is where we see the passage of the spinal cord and neurovascular structures, meninges surrounding the spinal cord. Okay, so vertebral foramen created by the vertebral arch coming and arching around posterior to the vertebral body, passage for the spinal cord and its associated structures. Now, in this lateral view, we have to have adjacent vertebrae together to see this foramen, the intervertebral foramen. The intervertebral foramen is this opening right here that's created by the articulation of the inferior articular facet here, or articular process, with the superior articular process here. Those coming together create this opening, and that opening is called the intervertebral foramen. Inter, I-N-T-E-R, I-N-T-E-R, as a prefix, means between 2 things of the same type. So like an interstate is a roadway that goes between states. So intervertebral foramen means a foramen that is made between 2 vertebrae. So this intervertebral foramen we see on the sides, the lateral aspects of the spinal column, and that allows for passage of spinal nerves. Those spinal nerves are then going to exit and go on to innervate our skin and muscle. Clinical pearl here is related to a laminectomy. So remember laminectomy, or remember a lamina. The lamina is this posterior projection here. Pedicles are coming straight off the back of the vertebral body. Lamina are coming here and then coming together to form the spinous process. If somebody gets too much compression on their spinal cord, on their spinal nerves in a particular area, conservative measures have failed, there may be, they may require surgical removal of one or more spinous processes and their supporting lamina to relieve the pressure off the spinal cord, and that's called a laminectomy. Sometimes further removal is required, but often they take just the spinal process off, cutting the lamina, allowing for opening and pressure to come off of the spinal nerve and spinal cord in that area. That's a that's a laminectomy, removal of the spinal process at the lamina. One other is spinal stenosis. So the vertebral foramen, if it gets, so this is a normal vertebral foramen, allowing for the spinal cord and associated structures to be protected and pass within. If we get stenosis, means narrowing. If we get stenosis in the spinal canal or vertebral foramen, we now get compression on the spinal cord and its associated structures, and that will cause neurological impairment. So that's spinal stenosis. Okay, so some regional characteristics of vertebrae. So we talked about typical vertebrae have similar structures, but there are very specific and unique structures for each region, cervical, thoracic, and lumbar, that I want you to know because I want you to be able to look at a vertebrae and know, is this a cervical, is this a thoracic one, or is this a lumbar one? And so some high notes here are listed here. So cervical vertebrae, small, very small, and small vertebral bodies. I bolded transverse foramen because that is often the easiest and most distinguishing feature here. A transverse foramen or foramen transversarium, foramen as a bony landmark identification, foramen means opening. And so we're getting an opening, a hole in the transverse processes of our cervical vertebrae. So transverse foramen are unique and only found in cervical vertebrae. The facet joints, the joints that articulate those articular processes with one another, are horizontally oriented. Off the vertebral body are uncus. We'll look at that soon. The uncus off the vertebral body allows for more mobility in the cervical spine. And then off the spinous processes, instead of having one unified projection and long projection off the posterior aspect here, we get short bifid spinous processes, kind of like a little fork. Most distinguishing feature in the thoracic spine are costal facets for the ribs. So thoracic spine associated with the thoracic cage, associated with ribs. And so we get facet joints for articulation with the ribs. We also get frontally oriented facet joints and downsloping spinous processes, which we will look at in a moment. And then finally, in the lumbar spine, very large vertebral bodies, more weight bearing happening there, large vertebral bodies to help with that. They have long transverse processes. Transverse processes are muscular attachments, and we get large stabilizing muscles anchoring in the lumbar spine, so that makes sense. Short, wide spinous process and sagittally oriented facet joints. So we'll go through these in just a little bit more detail here. So cervical vertebrae, our cervical vertebrae, cervical is associated with the neck, and our neck is quite mobile, so we can move our head and look all around our world. And so the cervical vertebrae are, the features of the cervical vertebrae all really help to make it more mobile. And so we have very small, as I mentioned, small vertebral bodies, and that vertebral body size in relation to the intervertebral discs helps for more mobility. You also see these little lips off the sides, these little lateral projections off the vertebral bodies. You can kind of see it here too, off these vertebral bodies. Those are the uncus of the cervical vertebrae, elevated superior lateral margins of the body. This allows for more mobility, especially in flexion and extension of the cervical spine. The facet joints are oriented more horizontally, so more in that horizontal or transverse plane. They're actually about 45 degrees off of that horizontal plane, so almost like a plane trying to take off into the sky. And that horizontal orientation allows for a lot of flexion and extension. It allows for lateral flexion or side bending and rotation. So all of those movements that we need our neck to be able to produce to move our head around our environment and see things. Again, I mentioned the transverse foramen. Foramen are foramen meaning hole, transverse in reference to the transverse process. So these are holes in the transverse process that are going to be the passage for the vertebral artery, which supplies blood to the brain. So transverse foramen, allowing for passage of the vertebral artery, unique and only found in the cervical vertebrae. And then short bifid spinous processes. So shorter in length and having a little fork, like a forked tongue, almost like a snake. Um, one more thing here is, so we get short all the way until C7. So we also often see in the transition points between one region and another. So at C7, we're about to move into the thoracic region. We see kind of a transformation and a transition from cervical traits to thoracic traits. And so the C7 is right before we get to the thoracic spine. And so C7 actually has quite a long spinous process. It's typically the most prominent in people, and so it's easily palpated. So the one exception to the short bifid spinous processes is this C7, which is the most prominent and is becoming and looking more like the thoracic vertebrae that are going to follow just below it. Two special vertebrae in the cervical region are the atlas and the axis. Atlas is C1. Atlas is like if you think of that sculpture of that strong guy carrying the world on his back, I think that is called Atlas. And so you want to picture this vertebrae holding your head up and picture that sculpture. So that's what Atlas does. The Atlas is C1, the head sits right on top of it. The Atlas C1, as I mentioned before, has no body and no spinous process either. It's just basically a ring. But it does have anterior and posterior arches. It has lateral masses that hold the cranium. So your occipital condyles of your head are going to sit right on your lateral masses. Okay, so you see that in this radiographic image. This is C2, this is Atlas or C1, and your head is sitting right on top of it. Okay. The lateral masses, again, articulate with the occipital condyles and form our yes joint, our nodding flexion extension to make our yes motion. And then we also see important here is this transverse ligament running in the transverse plane and is going to help secure the atlas to C2, which is called the axis. C2 is called the axis because it has this axis, this little pivot point called the dens or odontoid process. So we have the dens or odontoid process, this superior projection that creates an axis point for the head to pivot on and rotate in our no joint rotation. And then it has superior articular facets for the atlas to sit on top of. There are, again, no intervertebral discs between C1 and C2, but we have intervertebral discs throughout the rest of the spinal column, all the way to L5S1. Okay, so moving on to thoracic vertebrae. Thoracic vertebrae, I mentioned most characteristic distinguishing feature here is the costal facets for the ribs. There are 4 vertebral body facets, so 2 on each side. We have 1, 2 here, superior, inferior on the right side, and then on the left side. Excuse me. And then we have 2 transverse processes. Okay, so 1 transverse costal facet on the right transverse process and 1 transverse costal facet on the left transverse process. Okay, so again, looking at this image, superior and inferior vertebral body facets, and then 1 on the transverse process. Then we'd have the same thing on the other side. You can see here too, I talked about long down sloping spinous processes. these spinous processes are sloping downward such that the bony projection you're going to feel on palpation is actually overlapping the vertebral body of the one below it. Okay, so if you're looking for T4, for example, if you're looking to mobilize T4, say this is T4 and you're trying to mobilize it, you often want to go and count to T3. So that downsloping spinous process is overlying the one below it, and then you can mobilize as you wish. Okay, so long downsloping spinous processes overlapping the inferior vertebral body. And then I mentioned frontally oriented facets. Frontally oriented facets. So you see that facet joint off the articular process is almost straight up and down in the frontal plane. That orientation is allowing for rotation and side bending, but limits the amount of flexion and extension that can happen locally in specifically the thoracic region of the spine. All right, and then the lumbar spine. Lumbar spine, we mentioned very large vertebral bodies. You can see that in these radiographs. Largest typically is L5 as we have more weight bearing as you go down the vertebral column. You get very long transverse processes, but a shorter spinous process. And then we get articular processes and facet joints that are oriented in the sagittal plane. Okay, so they're oriented front to back. And that sagittal orientation allows for flexion and extension, allows for side bending, but limits the amount of rotation that is able to happen in the lumbar spine. And as I mentioned these facet joint orientations, I want you to know basically just at that level I have mentioned right now, but we will talk about the implications of that in more detail come the summer when we get to kinesiology. Again, you'll see on the outline that I mentioned that at L5S1, so where L5 meets our sacrum, remember sacrum is a fused bone, but we often call it still S1 here at the top. So between L5 and S1, remember I mentioned that at transition zones, we often get some shared characteristics where it's L5 is kind of transitioning into some of the sacral traits. And so L5S1 facets tend to be oriented more in that frontal or coronal orientation. And that helps kind of grip L5 to S1 and keeps it from slipping right off the top of your sacrum. Okay, so that's more for security reasons. Again, we'll talk about that in more depth and the implications of that for your spine and for movement and kines in the summer. So pin that for later. Uh, Sacrum and coccyx, again, fused bones. Sacrum is 5 fused bones. Coccyx is typically 4 fused bones. And the sacrum then articulates with your pelvic bones to form the pelvic girdle and transmit force from your head, arms, and trunk down through your pelvis and legs, and then force that comes up through your legs and up through your pelvis. On the sacrum, there are several landmarks I'd like you to be aware of. So first is the base. The base is this broad superior portion of the sacrum formed by the body of S1. And then there are articular processes called the ala. So this portion right here that I'm running with the laser pointer is the base of the sacrum. On the anterior portion of the sacrum, there is an anterior projection that's called the sacral promontory. So anterior projection off of S1 is called sacral promontory. In the posterior portion of, so this is anterior view, this is posterior view. In the posterior portion of the sacrum is an opening that is synonymous with your vertebral foramen. This is called the sacral canal, continuation of the spinal canal. It will contain the cauda equina, the horse's tail, which are the lower spinal nerves coming off your spinal cord, traveling through the remainder of the spinal column until they exit. And those spinal nerves are going to exit through foramina, or foramina are smaller openings. So instead of foramen, they get called foramina. Again, I apologize for coughing. I know it's annoying on recording. Um, so sacral foramina, there are anterior openings, so anterior sacral foramina, and there are posterior openings, and those are called posterior sacral foramina. Those are going to be for passage of either anterior rami of spinal nerves or posterior rami of spinal nerves. And we're going to talk about a spinal nerve when we get to our in-person lecture content. But the sacral foramina are the passageways for those. There are then on the sides of the sacrum auricular surfaces. Auricular. The first part of this or comes from aura, which means ear, and these look kind of ear-like. So the auricular surface is an articular surface for the pelvis. And it's going to eventually help form the SI joint. We'll talk about SI joint when we get to lower extremity. And then you have the sacral tuberosity here, which is this bony ridge that is also going to form a fibrous portion of the SI joint. Again, we'll talk about that again in lower extremity. And then you have coccyx. I don't remember if I have another slide for coccyx. No. So down here, coccyx, typically four fused bones. The coccyx is not weight bearing in any way, but it is an important attachment point for pelvic floor muscles. And we'll talk about pelvic floor at the very end of this semester. So joints of the spinal column, two important joints. There's an interbody joint and a zygapophyseal joint, also sometimes called, I will most commonly call it a facet joint or facet joint, depending on how you choose to pronounce it. Also, I believe Dr. McLennan likes to call it a Z joint. We're all talking about the same joint. So zygapophyseal, facet, Z joint, all are the same. But we'll start with the interbody joint. Again, in anatomy, it would be so helpful for you if you start to pick up on some of these relational terms and just like medical terminology and general prefix, suffix types meanings, because I mentioned inter means between two of the same thing. So this is an interbody joint. This is a joint between the vertebral bodies. And so between two adjacent vertebral bodies and the intervertebral disc between those vertebral bodies is your interbody joint. Now, remember from the foundational material that we can get two bony ends that come together with cartilage. And so that makes this a cartilaginous joint, and the interbody joint is a cartilaginous joint, also called a symphysis. So the interbody joint is a symphysis, which is a type of cartilaginous joint, and that is made up by the articulation of adjacent vertebral bodies and their intervertebral disc. The next joint is the zygapophyseal joint. The zygapophyseal joint, facet joint, Z joint, is the articulation between the inferior articular process, the facet of that inferior articular process, with the facet of the superior articular process of the vertebrae below it. And so you can see on this image, anytime on a drawn image like this that you see blue like this, that's them trying to indicate articular cartilage. And so off this articular process, we see this articular cartilage on the articular surface, which is called the facet. And so we get the inferior facet here with the superior facet here, creating a zygapophyseal joint, Z joint, or facet joint. That facet joint creates a plane type synovial joint. So these are relatively flat surfaces articulating with one another, and that creates small amounts of glide or slide between those articular surfaces, and all together, as you summate that glide over your entire spinal column, creates our collective movements at our spine. Okay, so interbody joints and facet joints, the two joints of the spinal column. Intervertebral disc, so the intervertebral disc is between each successive vertebral body except for C1 and C2. The intervertebral disc is made up of two important parts, the outer annular fibrosis and the inner nucleus pulposus. So the intervertebral disc, again, helps to create height. It creates about 20 to 25% of your spinal height, and it contains a lot of water. So that's why over the course of the day, you might lose a little bit of height as you start to lose some of that fluid out of as it gets kind of squished out over the tensions of the day. The intervertebral disc, we get weight loaded through here. It's squishing on that intervertebral disc, helping to absorb shock, provide some flexibility. Again, outside annulus fibrosis. Annulus means it is circling around the outside. It's annular, circular. And it's fibrosis. It's more of a fibrous tissue. Nucleus, it's on the inside. Pulposus, it's pulpy, it's jelly-like. So the inner nucleus pulposus is gelatinous, and that jelly absorption is being contained by the fibrous ring of the annulus fibrosis. Again, no disc between C1 and C2, and the last disc is between L5 and the top of the sacrum, or S1. The clinical pearl here is a herniated disc. So this is a fairly common thing for people to have. Herniated disc happens. Herniation, and as just a term, means movement of material out of where it belongs into somewhere where it doesn't belong. And so herniated disc is the movement of material from the intervertebral disc out of where it belongs and into somewhere it doesn't. That happens due to damage in the outer annulus fibrosis. So our containment system here has broken and that jelly is squirting out. So think of it like a jelly donut. You've got the jelly donut, jelly filling in the middle, the donut part on the outside, the jelly squirting out the donut. When that jelly squirts out the donut, it very commonly squirts out the back corners, and it will compress on the spinal nerve passing in that area or directly on the spinal cord. That creates then issue with the transmission happening in that area and down that spinal nerve, and that creates what's called radicular symptoms. Radicular, you'll learn further in your clinical coursework, is when you get those radiating symptoms specific to that spinal nerve, which sounds an awful lot like maybe muscular weakness specific to a single spinal nerve, maybe in a myotomal pattern, maybe numbness in specific areas of skin related to a single spinal nerve, which sounds like a dermatomal numbness, but also could be pathological reflexes and things like that related to herniated disc. So that is a clinical pearl herniated disc. Again, you'll add more complexity and deeper understanding to these clinical pearls as you move through your clinical coursework. But this is trying to provide you some initial appreciation for connecting normal anatomy to some common pathologies you'll see in your clinical career. Okay, so moving on. Well, actually, not moving on quite yet. So we talked about the two, excuse me, the two joints found in the spinal column, inner body joint and facet joint. But there are two additional joints related to our cranial vertebral region. So the articulation of our head with our upper vertebrae that allow for our head to move specifically. And so these are our atlanto-occipital joints. Atlantovertebral joints, I'm sorry. And the first one is atlanto-occipital joint. The atlanto-occipital joint is our yes joint. Atlanto-occipital is saying it is the joint between the occiput, occipital condyles of the head, and the atlas. Okay, atlanto is atlas, occipital is occipital condyles. So atlanto-occipital joint is the articulation between C1 and the occipital condyles of the cranium. This is a condyloid type synovial joint. Condyloid meaning that allows movement and it's multiplanar. And so at our atlanto-occipital joint, we get flexion extension, we get some lateral flexion or side bending, and we get some rotation, but largely we are getting flexion and extension. And that allows for our nodding yes. Okay. There's also a thin, loose joint capsule around this joint, which allows and it helps maximize our movement in that yes nodding motion. Okay, so that's atlanto-occipital joint. Very specific joint, only found right here between the head and C1. And then the other one is the atlanto-axial joint. This is our no joint. We're shaking our head no, right to left. And so there are three joints that create this atlanto-axial joint. There are two lateral joints, lateral atlantoaxial joints, one on the left and one on the right. These are essentially the facet joints of C1 and C2. Okay, so those facet joints are plain type synovial joints that are allowing for glide. But then we have a medial or median atlantoaxial joint, median meaning it's in the middle, like median plane. That median joint is between the dens of C2 and the anterior arch of C1, and then is held in place by this transverse ligament around the posterior aspect. That creates a pivot joint. We can see this projection of C2 within this opening here of the atlas, and we're getting pivoting motion. And this pivoting motion allows for the head and C1 to rotate side to side and create our no movement. So rotation is allowed at the atlantoaxial joint. Additional ligamentous supports here. We talked about transverse ligament. Transverse ligament is helping secure C1 and keeps the dens in place. It helps keep the head and C1 from just drifting forward off your spinal column. You also have these alar ligaments right here. The alar ligaments are going to be coming from the dens up into the cranium, and these are helping us not be like an owl. They help us prevent excessive rotation. And then you also have the tectorial membrane. We'll see that in a few slides. That is a continuation of our ligaments, our posterior longitudinal ligament of our spinal column. And this just helps, again, add some additional support of these upper cervical vertebrae to the head. It helps connect our spinal column to our head. Okay, so ligaments. It's important to frame ligaments as we move through this course as exactly what they are. Ligaments are connective tissue that connect bone to bone. And so we will talk about the ligaments in terms of movements that they resist. Now remember, in most joints, we do allow for some motion, so we do get motion, but we don't want too much. And so we're often describing it as limiting excessive motion in certain directions. And you want to picture a ligament's job as what if those two bony ends that it's connected to, in which direction do those two bony ends have to move farther apart for that ligament to become very tight and resist too much movement. Okay, so try to picture that. So I've listed the important spinal column ligaments here. They're helping to stable the vertebral column and limit excessive motion. First, we have the ALL, or anterior longitudinal ligament. The anterior longitudinal ligament is named for exactly what it is. So it's here on the anterior portion of the vertebral bodies, running along the anterior aspect. So it's along the anterior aspect of the spinal column of the vertebral bodies. And the ends of that anterior longitudinal ligament would be pulled apart as those bony ends move apart. And that happens as our spine goes into extension. So the anterior longitudinal ligament would prevent vertebral column hyperextension. So in this side view, this is the anterior longitudinal ligament. connecting anterior portions of the vertebral bodies. If this cervical spine went into extension, it would stretch that ligament, and that ligament would become more taut, creating stability, preventing too much extension. The PLL, posterior longitudinal ligament, is much smaller than the anterior longitudinal ligament. It runs on the posterior side of the vertebral bodies within the spinal canal. Same idea here. So posterior longitudinal ligament, posterior portions of the vertebral bodies within the spinal canal. It would get pulled more taut as the spine goes into flexion. So it's preventing hyperflexion or excessive spinal flexion. It also helps support, you can see it right here at the back of the vertebral disc. It helps support the posterior portion of the IV disc and helps resist the disc herniation. Next, we have ligamentum flavum. Ligamentum flavum is right here. Ligamentum flavum it means yellow. Flava means yellow in Latin. And so sometimes in the cadaver, it has a yellowish color. But the ligamentum flavum or flava is between adjacent lamina. And so we have the ligamentum flava between adjacent lamina. Anything on the posterior elements of the spine are going to move farther apart and thus pull on those ligamentous structures in flexion. Okay, so ligamentum flava, those laminae move apart, the ligamentous structures become more taut, resisting excessive spinal flexion. Interspinous ligament. The interspinous ligament is, as it's named, interspinous between spinous processes. So the interspinous ligament is helping, again, posterior elements become farther apart in flexion. And so interspinous ligaments would become more taut and support resisting excessive spinal flexion. Intertransverse ligaments, intertransverse between transverse processes. Those transverse processes are going to become farther apart. Picture you're going into side bending, that this transverse process would move up and away and pulling on that ligament. So intertransverse ligament is going to limit excessive lateral flexion, which is also side bending, and also during rotation. So limiting excessive rotation. Supraspinous ligament. Supraspinous ligament is coming off the very tips of the spinous processes from C7 down to the sacrum. So from here down to the sacrum is supraspinous ligament, helping to resist excessive spinal flexion. But up from C7 up to the head, we see this ligamentous structure, but then it's connecting to those spinous processes here. That's called the nuchal ligament. And the nuchal ligament is also helping to resist excessive spinal flexion, and then also helps support the head and is an important attachment point for muscular structures that we'll be talking about. And then here, some additional ones that I mentioned earlier. So purple here, tectoral membrane. I talked about that being the continuation of the posterior longitudinal ligament up into the base of the cranium. So this is the cranium up here. And then you have the alar ligaments. The alar ligament is right here, right and left side, projecting from the dens up into foramen magnum, helping to resist excessive rotation. And then we talked about the transverse ligament coming around the posterior aspect of the dens, helping to secure C1 on C2. Okay, so that's the end of this pre-recorded material for the back portion. We'll get into the rest of the back lecture in week 2.